Hello, and welcome to liver dysfunction. We'll start this part of this section with, we'll go over A&P of the liver, which is a big part of liver disease. And then we will talk about the different parts of how the liver starts to break down. We'll talk about cirrhosis. We'll talk about esophageal varices. We'll talk about hepatic encephalopathy, some liver cancer or hepatocellular carcinoma, and then we'll go into the different types of hepatitis. So this is a really big section. So I'll try to break it down into smaller parts for you so that you can take your time and really absorb the information. So again, it's really important for you to understand the A&P behind the liver, so that way when it starts to break down, you'll really understand what to look for your patient and why. So really hone in on this A&P of the liver. So let's move and talk about that in more detail. So here it is, the beautiful liver right in front of us. You can see it in the center, that nice big beefy red organ at the top. I'll point to it here. Okay. You probably know where your liver is located. If not, I'm going to tell you. It's in your right upper quadrant, and it's tucked away really nicely underneath of your right rib cage. So if you kind of dig your hand up underneath of your right rib cage, you might be able to feel that slick surface if you really kind of dig your hand and push up underneath of there. Unless you're coagulopathic, then don't do that. That's not good. But if you're not, you go ahead and feel. You can kind of feel the edge of that liver. It's tucked away nicely and deep up in there. The liver is very, very vascular. And you can see that by its nice beefy red color. So it is tucked away in there to protect it. So if anyone is to get into like an accident where there's trauma to that liver, it will bleed and bleed and bleed if it is traumatized. So that is really tucked away on purpose to protect it. So it has lots and lots of functions. If you're still trying to find your liver, kind of feel the other side, your left side, and you'll see that there's a difference. There's a lot more shallowness underneath that left rib cage compared to that right, and then you'll know that, oh, maybe I am feeling my liver under that right rib cage. So kind of feel your own, because you want to start to get used to feeling livers on patients if you're not used to it already. And we'll talk about that more as we move into assessment. All right, so the liver is full of functions. It has over 500 functions. We're not going to talk about all of them, but we will hit the highlights of what the liver does for us, so that way you can understand again when it starts to break down what the problems can look like for our patients. All right, so it's in our right upper quadrant. You can see all of the gut things that we talked about in pancreatitis here in a good picture. So here's our esophagus, where I'm pointing with my cursor. Let me move into our stomach here. Remember, here's our duodenum or duodenum if you're fancy, however you want to say it. Here it is. And then you move into your small and large bowel. Right here is your pancreas. Okay. You can see the liver right here. And coming from the liver, your right and left hepatic ducts, they bring that bile down, this common bile duct, as you know, through this sphincter of Oddi into the duodenum. Some of that bile sits in that gallbladder for when we need it. And then it will come further down, with the rest of that bile. Pancreas is here. You can kind of see that pancreatic duct. Right here is the spleen. It's that dark purple organ. Okay, so feeding our organ all of that blood that makes it that beautiful beefy red color is this big, big purple vessel. This is our portal vein. It's one of the biggest veins we have in our body. It feeds the liver 75% of its blood supply. So it's called the portal vein. Important for you to know, it's the portal vein. It gives the liver a majority of its blood supply. So it's all that gut circulation comes up through that portal vein and feeds the liver. The other 25% of the liver's blood supply comes from, you can see this red artery here, feeds the liver. It's oxygenated blood. So you have deoxygenated, nutrient-rich blood from the portal vein, goes into the liver, and then oxygen-rich blood from the hepatic artery also feeds that liver. Not shown in this picture, but certainly present in our body, coming from the liver, the blood doesn't just stop here. So from the top of the liver, if you can imagine, there are hepatic veins, and those will drain the liver of the blood once it gets through that liver, and the blood will leave the liver through what are called hepatic veins. The blood that leaves the liver through the hepatic veins will ultimately enter the inferior vena cava, and then you know where it goes from there. It goes to the heart, so that way we can pump it through our body. Right, so that is how the circulation of the blood through the liver works. Right. You can see on here, this is important for later, this big, beautiful portal vein connects to another purple vein here. This is our splenic vein. This is our splenic vein, and it connects to the spleen, which is also full of lots of blood. You can see that dark color, lots of blood in that spleen, and you know that already from previous content that you've had. So the splenic vein connects to the portal vein and all goes together to that liver. Okay. All right, so on here is just a recap probably of most of the things we talked about, I believe, so that you can read that at your leisure. Okay, here is a schematic of the portal systemic blood flow for those of you who like to think in schema. This is kind of a picture of the portal systemic blood flow. So important term for you to understand when we talk about liver and gut circulation. We talk about what's called splanchnic circulation. So this splanchnic circulation is all of our gut circulation. So our arterial blood supply and our venous drainage of the entire GI tract. So this is all of our blood flow from our distal esophagus, so the lower part of our esophagus here, all the way to our rectum. So all the blood flow from our distal esophagus to our rectum is called our splanchnic circulation. So very important if you understand what the splanchnic circulation is. It's our gut circulation from our distal esophagus to our rectum. And it's important because as we talk more about the medications that we use for liver dysfunction, a lot of it affects the splanchnic circulation. So it's really important for you to know what that entails. Okay, so before we talk about liver labs, let's talk about the functions. Yeah, let's talk about the functions of the liver. Okay, let me see if I can stop my share and see. I'll draw them on the board for you. Okay, so the liver, like I said, has over 500 functions, and we're not going to talk about all of them. We'll talk about some of the major ones that are important for you to understand about the liver. All right, so we'll categorize these for you. All right, what we'll do is we'll categorize them. Let's see how high up we go. Maybe here. All right, the liver is a big, big producer . It's a big producer. All right. It is also a big detoxifier. Detoxifier, so all right, detox. The liver, as you saw, the big beefy red organ that it is, it's a big storehouse, so it's important for storage. And can classify the next part as the concept that we're talking about here, metabolism. So we know that the liver is has an important function in metabolism. And, all right, so as a producer, the liver has lots of things that it produces and synthesizes for us. Maybe we can categorize them in alphabetical order, so that way when you're studying it will help you. Let me do it over here. We have more room. It produces that's A, B, C, and C. Okay, So A for albumin, we know that the liver produces our albumin. We talked about before the role of albumin in our intravascular fluid volume regulation. We know that albumin is a big regulator of, this is albumin in our intravascular space, this big intravascular plasma protein. We know that it helps bring our fluid into the intravascular compartment so that our intravascular compartment can stay with the fluid in it where it belongs. Okay, so albumin is, the liver produces albumin, and albumin is a good intravascular fluid magnet. It's a fluid magnet in general. So when we have good levels of albumin, it keeps our intravascular compartment hydrated, and it keeps the fluid in that intravascular compartment. So as you can imagine, a patient that has liver disease that does not have a lot of albumin, low amounts of albumin because the liver can't produce it, they don't have a lot of albumin in that intravascular space, maybe they have one, where do you think the fluid might go? There are spaces. So a lot of times in patients with liver disease, we will see patients with low levels of albumin. As the liver disease progresses, we will see lower and lower levels of albumin in these patients, and we will see them with third spacing edema. Like we will see them have edema, we will see them particularly have ascites in these patients, and everywhere edema because they have low albumin, so they can't keep that fluid in the intravascular compartment. Albumin is also very important, aside from its role in keeping the intravascular, the fluid in the intravascular compartment where it belongs, for the most part. Another big thing that albumin does for us is, as we talked about, it carries calcium. So we need albumin to carry our calcium. That says Ca for calcium. So for a patient with low albumin, we can anticipate that they will have a low calcium. So we need albumin to carry calcium. That's one of the things that it does for us. So it's important because it carries calcium. Albumin is also a big carrier. It's a big, strong plasma protein. It carries calcium. It carries other things like hormones for us. It carries hormones. And another big important thing that it does for us is it carries drugs. So it carries as a drug transporter. So if a patient has liver dysfunction, the patient may not be able to carry the drugs to the right places. Or may not be able, might have more free drug in their body, so they would be more toxic to the liver because it's not able to move that drug where it needs to go. Right. So albumin has a very important role in our body. So patients with liver disease with low albumin suffer from things like edema, ascites, third spacing, not able to carry their hormones the right way, and then their drugs are not distributed where they're supposed to be distributed to. And this can lead to hepatotoxic effects of drugs. All right, the liver is a producer of B for bile. We need bile to help us absorb our fats. In a patient with liver disease, if we're not able to absorb our fats, we know already, similar to chronic pancreatitis, we know if we can't absorb our fats, then we will have what's called steatorrhea and malabsorption. So without bile, if we have low levels of bile because the liver can't produce it because it's in, has dysfunction, we will have steatorrhea and we will have malabsorption. So if we can't absorb fats, we also, again, can't absorb our fat-soluble vitamins like our A, D, E, and K. So we know that our patients will be deficient in A, D, E, and K as their liver continues to fail. Right, so our liver is important to produce albumin, and it's important because it produces bile. Another thing that our liver produces is cholesterol. We need cholesterol. We don't like a ton of cholesterol, but it does have some cardioprotective functions. in good levels. So we need cholesterol. It also helps us to also distribute our hormones. So patients with liver disease will have lower, as the liver disease progresses, they will show lower levels of cholesterol. Another real big function of production of our liver, it produces our clotting factors, or our coagulation proteins. Clotting factors, clotting proteins, very, very important. Most specifically, it produces our vitamin K dependent clotting factors. How we measure this in the blood for our patients with liver disease is we measure their INR. As you know, to make a clot, you can recall, it takes lots and lots of different pieces in that coagulation cascade in order to make a clot. If we are missing parts of our clotting factors because the liver is not able to produce our vitamin K dependent clotting factors, we will have problems with bleeding. So we measure how efficiently they're able to form a clot with their INR. You'll measure their PT-INR, but we use the INR to track their liver disease. Okay? So normal INR for a regular human that does not have liver disease and someone that is not taking Coumadin, because we know for Coumadin we have different targets for our INR. For a patient that does not have any impairment with their liver, that does not take Coumadin, and doesn't have any other bleeding dyscrasias, their INR should be, a regular INR should be less than 1. So I underline that I in INR. Normal INR should be less than 1. It helps me kind of remember it. So INR should be less than 1 for a regular human. Patients with liver disease, as earlier stages of liver disease and as the liver disease progresses over time, their INR will start to decline. So you'll start to see an INR of a 1.2, 1.5, 1.7, 2, 2.3. And these patients will be coagulopathic. It will be difficult for them to stop bleeding. So they're bleeding risks. So our patients with liver disease, we think of the production of the liver. So it produces albumin, which helps us with our intravascular, fluid, keeping it in there, carries calcium, helps us carry our drugs. We need it for bile production. We're going to have some steatorrhea and fat-soluble vitamin deficiencies. Helps us produce cholesterol, and it helps us with our clotting. So far you can see the value of our liver. I don't know if I mentioned, but you can't live without your liver. You can see so far all the things that the liver does for us. So important for you to know these things so that you can understand when the liver breaks down, what the patient will look like when they're struggling with liver dysfunction. The liver is important in detoxification. The liver detoxifies every single thing that we take in through our mouth and through our skin. So if we put lotion on our skin, it will help us to detoxify whatever chemicals we just put on our skin. So we think about sunscreen, we think about lotions, all of these different things that get absorbed through our skin, and they get first through the liver, If we take in any medications, if we take in alcohol, if we take in herbal supplements, all of these things have to first go to the liver to be detoxified before they enter our general bloodstream. Right? So I think about it detoxifies anything that has toxins. So anything like alcohol, herbs, any of those things I just mentioned. Simple things that we take in every day, like fruits and vegetables, if they have any pesticides on them, if they're like not organic, or if they have any type of thing on them that can hurt us, the liver will take that hit for us. So the rest of our systemic circulation does not have to suffer that hit. So alcohol, herbs, drugs, anything, the liver will detoxify these things for us so our body can not have to worry about it. The liver is a big storehouse. So it's a big, big red storehouse, and it stores many things for us. It stores things like iron. Fe is iron. It stores vitamins for us. So for a patient that has liver dysfunction, you can imagine, particularly B vitamins. B vitamins are important, and other vitamins. So for a patient with liver dysfunction, you will see anemia. You will see some folic acid deficiencies and B vitamin deficiencies in these patients. They're not able to store it. It also stores glucose in the form of glycogen. So this is a great function of the liver because you think about when you're out exercising or doing anything, if you use up all of the energy from the food that you just ate, the liver can break down some more glucose because it stores it as glycogen. So when we need it, we have extra on reserve. I always think about our patients with end-stage liver disease. They start to work with physical therapy and, they're down at the end of the hall and then all of a sudden they're hypoglycemic and they're sweating and they're exhausted. And we're thinking, are they deconditioned or, is this a blood sugar issue? And 9 times out of 10, it's a blood sugar issue because they don't have that backup glucose to hold them over because their liver's not storing extra glucose for them to just kind of churn out as they use more and more glucose. They don't have that extra on reserve like the regular person would. So you check their blood sugar and you see that it's very, very low, and then you have to give them supplemental blood sugar, glucose. We often tell patients to carry around glucose tabs if they're going to be doing anything extra than they usually do. All right, so it stores glucose in the form of glycogen. So patients with liver dysfunction will often suffer from hypoglycemic events, not uncommon for these patients. All right, and finally, that we are in the section of metabolism. So it's important to understand how the liver works to metabolize things for us. The liver is important. It metabolizes things like our proteins, carbohydrates. So CHO3 is carbohydrates. A big one, ammonia. Ammonia is a big thing that our NH3 is ammonia. Ammonia is a big chemical that our liver will metabolize for us. As the liver breaks down, our liver is unable to metabolize ammonia, which is a big problem. So ammonia is a byproduct of protein catabolism. So when we take in protein or when we have protein in our body, it needs to be broken down so we can clear it. Usually the liver can catabolize or break down ammonia and turn it into urea so our kidney can clear it and we can get rid of excess ammonia. When the liver is impaired, it can't do that. Ammonia is a very, very toxic chemical. It is neurotoxic, so it's toxic, upstairs to our neurologic, function. If we can't clear it and we have an accumulation of ammonia, it's not good for us from a neurologic perspective. So as patients advance through the stages of hepatic dysfunction, they end up, in hepatic encephalopathy, which is later in the progression of liver dysfunction. We start to see them have neuropsychiatric symptoms. They start to develop hepatic encephalopathy and ultimately end up in a coma as their ammonia levels increase. So you will see they're not able to metabolize their ammonia, and this will start to accumulate as the liver disease progresses. And this is a bad sign because the liver is really failing when they can't metabolize their ammonia. It is a CNS depressant or a central nervous system depressant. So this is really bad for these patients when they accumulate it because their central nervous system becomes depressed. And again, they can become encephalopathic from this and they end up in a coma. So it's not good for these patients. We want them to have neurologic function, so not good. All right, and it also metabolizes hormones for us. So I'm talking about our sex hormones, like our testosterone and our estrogen. So in the patients that have liver dysfunction, I think about our men patients, they start to have lower testosterone and higher levels of estrogen. So they start to have more female presentation. Like we'll see in a man that has liver dysfunction, we'll start to see them have things like gynecomastia or breast tissue enlargement in a man. We'll see them start to have things like testicular atrophy if they have liver disease. We'll see them start to have things like, from the low testosterone levels, we'll start to see them have things like muscle atrophy. So their arms will start to look more saggy, where they usually would be able to build up muscle. They're not able to because of that disruption in hormone metabolism because of the liver disease. We'll see them have loss of sexual dysfunction and maybe loss of sexual hair. So they won't have regular hair where they should, maybe under their arms and in their genitalia. For a female patient with liver disease, they will start to have higher levels of testosterone and lower levels of estrogen. So you'll start to see things like male pattern baldness in like a cul-de-sac pattern on the top of their head. They'll start to have things like hirsutism, so like hair on their face, like hair in this area first, and then it starts to develop on their face. They'll start to have things like amenorrhea or changes in their menstrual cycle. And also, of course, they'll have things like loss of sexual function too. They'll have difficulty with sexual desire and things like that. So these are things that we see in different genders of patients because of the hormone disruption or hormone metabolism problems in liver disease. Right? So it's important for you to understand how the liver works and these major functions of the liver as you study and go forward. If you understand these in good detail, you should be able to work through as we go through in more detail and understand the AMP and where the liver is located. So this should really help you. These are the highlights that you'll need to understand. Okay, let me see if I can stop my share here. Okay. All right, so we'll talk about the labs, and we'll start with, we'll start with the liver function test. So we'll talk about the liver function tests first. So the LFTs are liver function tests. Like you'll see them termed as LFTs or liver function tests. There are many different tests of the liver that we do through the blood. So the first two that we'll talk about are our serum aminotransferases. These are RLEs, or liver enzymes. These are the enzymes of the liver. And I spelled out what they stand for here in your comments. So there are two, the AST and the ALT, and you've seen these on your lab sheet every week. So what these indicate are acute liver injury. So the AST and the ALT are liver enzymes, and just like cardiac enzymes, you see cardiac enzymes increase when there is acute cardiac inflammation. When there is acute liver inflammation, similarly, you will see an increase in your liver enzymes. So whenever there's acute liver injury, your liver enzymes, which are your AST and your ALT, they will rise. Okay, and same thing in acute pancreatitis. When you have acute pancreatitis, your pancreatic enzymes will rise, your amylase and lipase. So you see a trend here. Whenever there is acute inflammation of these organs that we just talked about, the enzymes will spill and you'll see a rise in the bloodstream. So the AST and the ALT are good indicators of acute or recent liver injury. These are really good indicators of acute or recent liver injury. So you'll see levels of AST, ALT 3 to 4 times the normal value. Your normal AST is 10 to 30. Your normal ALT is 5 to 35. So 10 to 30 and 5 to 35. So I generally think like greater than 35 for both of them. That helps me remember. You can kind of keep that in your mind as a general rule, because a low value is not going to really do you any good to memorize. So I kind of think greater than 35 for both of them. And I think, okay, then we're going to be 3 to 4 times that level. Then I know that we're having an acute liver injury. Certainly you can memorize the range if that helps you. Whatever works. All right, so high AST, ALT tells you that you've got an acute liver injury. Now, of note, the AST is also released or will increase in other organ problems. So the AST is also present, in other words, in skeletal muscle, it's present in cardiac muscle, it's present in some bones and things like that. So you may see an AST rise all by itself without the ALT rising. And that just tells you that the injury that's going on is not specific to the liver, maybe somewhere else. But when you see the AST, ALT rise together, we know that it's an acute liver injury. I always think the ALT, the L in ALT stands for liver. So I know when that one's rising, and we've got something acutely going on in the liver. And they both rise, but the ALT is specific to the liver. All right, so these are good indicators when they're really high, 3 to 4 times the normal, of acute liver injury. So if someone comes in with a toxic, maybe overdose of, say, Tylenol, or acute hepatitis, you will see the AST, ALT rise. But if someone has maybe long-term chronic liver disease like cirrhosis, you won't see a rise in AST, ALT. This is only going to rise in acute liver disease. So this is a good indicator of acute liver disease. Protein studies, we look at our serum albumin. And we talked about earlier that the liver makes albumin for us. So as you can imagine, in liver disease, the albumin will be low in liver disease because we're not able to produce it as our liver starts to fail. This is a really good, the serum albumin usually is 3.5 to 5, just like potassium. So the serum albumin is a really good indicator of chronic liver disease. So in other words, if someone comes in with that acute hepatitis or maybe an overdose of Tylenol or whatever the case may be that brings them in acutely, their albumin will not take a hit. It will stay normal, between that 3.5 to 5 range. It's only the patients that have the chronic liver disease that will start to show a drop in their serum albumin. And the reason for this is because the serum albumin has a very long half-life. In other words, we can compensate because we have extra, it takes long to clear it, so we have extra on reserve. So it takes about 100 days before we start to see a hit in our albumin. The half-life is 20 days. So it takes about 100 days before we start to see a hit in our albumin. So initially, if there's an acute injury, you won't see a drop in the albumin. In other words, it takes about a long time before that albumin starts to take a hit. All right, so these liver enzymes, if someone has acute injury, you'll see them rise. If they have chronic injury, they'll stay the same, normal range. Serum albumin, if someone has an acute injury, they stay the same. If someone has chronic liver disease, you'll start to see the albumin drop. Okay. And when the albumin drops, you'll start to see edema and ascites and those kind of things because we can't keep that fluid in the intravascular compartment. Our PT-INR, as you know already, we have problems because the liver makes our clotting factors, or vitamin K dependent clotting factors. We measure that with the INR. So normal INR is less than 1. So the PT-INR ratio is about 10 to 1, 10 to 12 to 1. So it's important for you really to understand the INR. So INR for a normal human is less than 1. When you have liver disease, our INR will start to go up. So the INR measures the time required to form a clot. So it takes longer to form a clot as our liver is impaired because we can't make those clotting factors if we don't have a functioning liver. So it takes longer to make a clot. So INR is measured in its time. So it takes time to make that clot. So it takes longer and longer to make the clot. So the INR increases in time. Okay, so patients in either acute or chronic liver disease, you will start to see increases in INR. So this is a good indicator of both recent acute liver disease and chronic liver disease, PT-INR. So our INR will start to rise if someone, let's say that they have acute hepatitis and they come into the emergency department, or they have acute Tylenol overdose, or whatever they did an acute injury to that liver, you'll see a rise in that INR. Similarly, if a patient has chronic liver disease like cirrhosis, you will see a rise in that INR. So for any type of injury to that liver, that INR is going to take a hit. So anytime any patient you care for has any type of liver disease, be careful because they'll bleed. Very important. Be careful because they're bleeders. Be careful with your liver patients because they will bleed, acute or chronic liver disease. Protect them at all costs. Any type of safety you can throw in for these patients. All right, so they'll start to climb. That INR will be 1.2, 1.5, 1.7, 2, 2.3. You know, they get up to the 7 range, we're in big trouble. They spontaneously bleed on us. So be real careful with your liver patients because they can bleed. Okay, so here are some more examples of our liver enzyme or liver function tests rather. Lots of things this liver does for us. Okay, so we'll talk about these and then we'll move on to jaundice and then we'll go back to the pigment studies. I think that's the best way to do it. Okay, so we'll talk about, there are pigment studies that the liver performs for us, and the liver is able to conjugate bilirubin. I don't know that we talked about that, but okay, one of the functions of the liver, it produces bile. Bile carries our bilirubin for us through our biliary tract or our biliary tree. And we'll talk about that in more detail. But bile not only helps us to absorb our fats, but it helps us to carry our bilirubin through our biliary tract or our biliary tree. So we'll talk about that in more detail. So we will need to measure our bilirubin. So our bilirubin is a combination of, our total bilirubin is a combination of our direct bilirubin and our indirect bilirubin. So our direct bilirubin is also known as our conjugated bilirubin, and our indirect bilirubin is also known as our unconjugated bilirubin. So direct plus indirect equals our total. That's how that works. It's just simple math. So when you get your labs back, you'll get a total bilirubin, and that will be a combination of both your direct and your indirect. So it'll display all of those values for you, but know that the total is both a combination of your direct and your indirect. So as you can imagine, a high direct or conjugated bilirubin, if you have a high direct or conjugated bilirubin, then your total will be high. Similarly, if you have a high indirect or unconjugated serum bilirubin, you will have a high total bilirubin. Or if there's something that's causing a high direct and indirect bilirubin, you will have a very high total bilirubin. So we'll talk about those in more detail here in a minute, but just understand that the total is a combination of both the direct or conjugated bilirubin and the indirect or unconjugated bilirubin. All right. There's also urine bilirubin. We should not have bilirubin in our urine, not conjugated bilirubin. That's called bilirubinuria, and that's not good. That means that there's a problem with the bilirubin metabolism. All right, alkaline phosphatase. I will draw out for you in a minute here. Our normal alkaline phosphatase is 0 to 90. It's 0 to 90. And we will talk about that in detail. Let's go through the other ones first. Serum ammonia, the normal level for you guys is going to be 15 to 45. 15 to 45 is your normal serum ammonia. As you know, ammonia is a byproduct of protein catabolism. As the liver becomes more and more impaired, we're unable to metabolize that ammonia. So liver usually converts ammonia to urea. When the liver is impaired, it's not able to do that. So our ammonia level will start to rise. Again, ammonia is a CNS or central nervous system depressant, and it is a neurotoxic. So the more ammonia we have on board, the more neurologic symptoms we're going to have. So the patient eventually ends up in a coma and will need a liver transplant. So this is not a good sign. This is end-stage liver disease when we see high ammonia levels in our patients. All right, cholesterol, as you know, the liver makes cholesterol for us and helps produce cholesterol for us. So as patients progress through liver disease, as you know, they will start to have lower levels of cholesterol. Not important for you to know the levels of cholesterol. If you want to, that's fine. It's not important for you to know too much about the levels of the bilirubin. We'll talk about the one that's the most significant for you to know here in a minute. Okay. All right, let's talk about jaundice, and then we'll go back and we'll do the bilirubins. All right, so, and we'll talk about alkaline phos at that time too. All right, so jaundice, you may already know if you've seen this in practice. This is the yellowing of the skin, and it's caused by elevated bilirubin levels. So we'll talk about it first, and then we'll talk about the different types here. All right, so this is also known as icterus. You can see yellow skin. I don't know if you've seen it in practice, but you can definitely see it. It starts off when the patient starts to develop higher bilirubin levels. You start to see it in the sclera of their eyes, and then you'll see it if you pull down their lower lip. You can see it in their mucous membranes. So that'll be the first sign. If a patient has darker colored skin, you can look on the palms of their hands and the soles of their feet. That will, those are earlier stages. You can see it a little more yellowing than usual. Then as patients, their bilirubin starts to increase, you'll see it more overtly on the outsides of their skin. So it all depends on the level of bilirubin that they have. This is caused, again, jaundice is caused by elevated bilirubin levels in the blood, so it's also termed hyperbilirubinemia. Some symptoms, patients will complain. If you've taken care of a patient, you know this already, it's very itchy because the bile salts are deposited on this patient's skin. So it's very itchy for them, very, very itchy. Not good if they scratch, because remember they're coagulopathic, usually if they have liver disease. So if they're scratching, they're at risk for infection because they can open their skin, but they also can get, really bruised up, and they can, it's harder for them to clot. So we're really careful to make sure that we, implement nursing interventions so that they're not scratching. We've had patients that have been encephalopathic in the past. They just can't stop scratching, and they're just not in the right state of mind. We've had to put those mitts on them to protect them. They're almost like, I think we have to get an order for restraint for them in some places, so that they're not scratching their hands. But, we try to put things like lotions on their skin to stop the itching if we can. We can do things like an oatmeal bath. Depending on how their liver functions, we can liver function test. We can do things like maybe antihistamines, depending on how their liver functions. Some patients, they don't qualify for that, but it really depends. So we do whatever we can as far as nurses. We want to do things like a cool rag, not a hot rag, to kind of wipe down that skin to help with that itching and mast cell production. We don't want to keep them hot. If they're warm, then it makes them itch more. If you've ever taken care of a patient with jaundice, then you know that if they sweat or they get wet, it kind of drains onto their clothing or onto the sheets of the bed. If you rub like an alcohol pad to do an IV on the patient, you'll see that yellow pad, after you wipe the alcohol on them, it turns yellow. So we're real careful to do teaching if these patients, if it's a new condition for them, they need to know maybe wear dark clothing is good. If you think about their mucous membranes of their eyes, their sclera, if they come in to the hospital with contact lenses, we'll take those out immediately, put them in like a saline, little container for them to take home so it doesn't wreck their contact lenses. So we're thinking of all of these things as we're caring for the patient with jaundice. Commonly, we start to see clinical evidence of a patient that has jaundice when their serum bili is greater than 3. So I think total bili greater than 3, it all kind of rhymes, start to see jaundice. Bili greater than 3, jaundice. You may see it when the patient starts to have a bilirubin of 1.8 or 2. Really depends on the patient, but typically we usually see clinical evidence of jaundice when the bili is greater than 3. So if I look at the labs and I see a 3.2 bilirubin, I know that I'm going into a room where the patient is very yellow skin. So I know that I'm going to start my teaching about, antipruritics, oatmeal bath, and I'm going to start to do all that teaching with this patient at the bedside. Okay. So the types of jaundice we're going to go over are hemolytic, hepatocellular, and obstructive. Those we'll draw out here next, and I wrote some comments about them underneath. So what I'll do is I'll stop it here, and then we'll come back and we'll talk about alkaline phosphatase. We'll talk about the lab itself, what it does, and we'll talk about the different types of jaundice.